Welcome to From Nothing, the podcast where we go deep with healthcare founders on how they actually got started in this crazy industry. I'm Ian Sefferman, alongside my colleague Patrick Haig. Today we're joined by Spencer Hutchins, co-founder and CEO of Concert Health. Concert Health provides exceptional behavioral health services for primary care practices. Keep listening to hear the creative ways Spencer has used to find startup ideas in healthcare, how he validates those ideas extremely quickly, and how to align incentives and sell into independent providers and health systems. Spencer, thank you so much for joining us.
Awesome to be here.
Maybe we can just start with the simple things, which is give us a 60-second summary of you, your background, and then a 60-second summary of your company as well.
Yeah, so first, thanks for having me. It's fun to have these conversations. I'm a second-time founder in the kind of digital health space. First one called Reflection was a software company that helped reimagine how people would prepare for and recover from joint replacement surgery. Before that, I'd spent close to a decade kind of at the intersection of health and technology, worked at a family office for a bit doing Series A, Series B investments. Earlier in my career as a management consultant, cutting across those two industries, and then would take some periodic breaks to do public service work. So I was in the first term of the Obama administration, helping start a healthcare team at the Federal Communications Commission, which was a blast. The business that I've been building for the last 3.5, 4 years is called Concert Health. We're trying to be America's best and largest behavioral health medical group. So while there's very much technology that we're building and a great team around that, the vast majority of our team members are clinicians. And our take on the market is to really help integrate behavioral health services into people's primary care settings or pediatric settings or women's health settings. So we're up to about 160 clinicians that work for us remotely. And then we provide kind of turnkey services alongside 56 medical groups and health systems in 8 states, so that patients can receive care for depression and anxiety right alongside their other health conditions, whether it's obesity or diabetes or pregnancy. And so we any given day are connecting with thousands of patients via video, phone call, or sometimes inpatient care to understand where their symptoms are for those conditions, sort of intervene using a mix of psychotherapy and medications, and then really holding both the patient and ourselves accountable for improving their care.
Oh, very cool. So I'm really interested in this conversation to talk probably about two main things. The first is, how the heck do you guys integrate with these primary care clinics? What is it like to work with those providers? And then the second thing is sort of, how did you guys get this business off the ground from day zero? And we've talked before, and you guys went through sort of a accelerator for repeat founders is the way that I think you described it. Can you talk us a little bit about like what was like day minus 60 or
Sure.
When you first started that?
Yeah, so I had stepped away from an operating role at Reflection, later had an exit to a large orthopedic business, and was sort of searching for my next thing. I'd gotten addicted to starting things, although I left Reflection with a lesson of, I thought I over-focused from the beginning with my co-founder that it had to be a technology business, it had to be software, because that's what you did when you moved to California. That's what scaled. That's what venture capitalists want to do. The software in healthcare is broken, and all that was true. But it's not. It's normally not the only story, right? And so normally there's other reasons, not just the apps stink, right? There's other things. The revenue model is not aligned with our values. It's not aligned with the clinical model that works, right? So it doesn't treat patients humanely, drive outcomes in a way that makes sense for people. And sometimes you can solve that just by building software. Sometimes you need to do something different. So I was starting to think of that, doing a little consulting, poking around. Was working with a friend to try to create what we thought would be a really interesting palliative care organization, and didn't quite get there, right, on lining it all up, and got a call from someone who had done a program in Denver. At the time, it was called 10-10-10. Now they call it X Genesis. But it was Tom Higley there, who was a multi-time technology founder, been very involved in Techstars. And he had an interesting thesis, which was that sort of the support programs for entrepreneurs were overwhelmingly focused on first-time founders. So whether it's Techstars or Y Combinator, and so it was sort of bring us an amazing existing business, early idea. We help you learn about, how to scale it, how not to get screwed by investors, how to set up a cap table, all those things. And his thesis was that there was actually another universe of founders that had already done it once before, and that really needed exposure to great ideas, often wanted their next business to be maybe more mission driven than their first. And also his thesis was that too often multi-time founders take B ideas and get them too far because they're like good at it. They have too much credibility. They can get invested capital, build teams behind things without having really done diligence on what they call wicked problems. And so the basic idea was, hey, got to find founders that haven't committed to their next thing, but have done a company before, and fly to Denver for 10 days with 10 other people and get exposed to 10 wicked problems in healthcare. They've now expanded to not just health, they do it in sort of various city programs like water, they did it as well. And the idea is sort of all expenses paid, learn a ton for 10 days. If you don't find anything interesting, move on, good luck. If you do, kind of we'll support you for that year and get on the cap table in a small way for sort of being there at the beginning. So it sounded great. That his sister lived in Denver and said, let's go do that. I'm not sure this palliative thing's going to kick off anyways. And so met 9 amazing other humans that I got to know really well, and then got exposed to 10 problems, one of which was behavioral health, which I was fascinated by. It was an area that I didn't have a lot of professional background in, other than knowing it as something in the US healthcare system that people think about as even more broken than most in terms of access and quality. And then, like everybody as a person, had seen just what great care can do for people that I love, and how easy it is in the United States not to get it, right? And so got fascinated with it, narrowed in pretty quickly in the first day or two of the 10 days, and then spent 8 days getting really smart, and found a nugget there, which was this model of care called collaborative care, which is a model that we've really architected Concert Health on top of.
Well, what was it like for those 8 days? I mean, like 8 days is a pretty short amount of time to get smart on something, but it sounds like you actually, you basically came up with the kernel of what you're still operating on today within those 8 days. So like, how did you go about doing that?
Yeah, I think one reason they've moved away from 10-10-10 is it's not a 10-day program anymore, because they realized that was an unrealistic. That's a nice cannon shot, but often take more. What I thought, it was a mix. Some people that were brand new to healthcare, which was really drinking out of the fire hose. For me, someone who came from inside the industry, had done others. What was great about it was they had assembled a group of really talented Colorado executives from health systems, health plans, analytics shops that were just sort of agreed to be egregiously available for you for those 8 days, right? So as an example, there was a program that Kaiser in Colorado had that was similar to this model, and kind of like at 11 o'clock, I slacked someone, on the program and said, hey, I'd really love to learn about Kaiser. And like that, the next morning, like 10 a.m., I got 45 minutes with the administrative leader and the medical director. And like, as someone that's well networked in healthcare, I probably could have gotten that meeting, but like maybe eight weeks out, or something like that. And so just sort of the rapid cycle of learning, understanding, and validating ideas was really the superpower of that, program that got me addicted to it, and really helped me crystallize within a 10-day window. It wasn't as though the business was like formed on day 10 and we were running or anything like that, but it certainly had convinced me in that 10-day window that, hey, I'm going to go home and try to convince my wife to let me not get a job for a little while and chase this thing down.
Okay. And so the collaborative care model that you came up with, like, you started reading about it. Was it you started reading studies that like evidence-based studies that were like, oh, this actually improves outcomes type thing?
Yeah, so collaborative care is an evidence-based model of integrating behavioral health services into primary care. And basically, it's recognizing that primary care physicians are the de facto mental health care system in this country. They already write most of the antidepressant prescriptions They are the clinician that most people trust and are engaged with. And there aren't any like psychiatrists looking for more patients. So even if we had people that were willing to get help, there's no access to just sort of fill out more psychiatry slots, right? And so if medicine is going to help, it's got to be, a lot of it has to be done by your GP. Basic model is, okay, we've got a set of imperfect interventions for depression or anxiety. It's a bunch of evidence-based psychotherapy interventions, or a bunch of meds. Not everybody wants them or needs them, and also we don't know what's going to work for who perfectly. There's some exciting advancements that are happening in epigenetics that help you understand some of those things, but we're still in early days. And so it said, listen, we've got to get our arms around everybody by screening everybody. It's sort of some basic questions you can ask folks at least annually or around a major health event that helps pick it up, because we know that probably half the people with depression or anxiety don't realize they have it. And then if you screen positive on those, to be able to make a warm handoff to what we call a behavioral care manager. It's someone that's a therapist, right? It's someone that's a licensed behavioral health provider, but they can really do a spectrum of interventions, some of which look very much like outpatient therapy, some which can look more like goal setting, symptom monitoring, check-ins, whatever a patient wants and needs, but always guided by re-giving those same screening tools so that you're really assessing whether or not you're getting better or not, and maintaining that in a registry, which is just a fancy name for a database that tracks whether or not you're getting better and what tools, what therapy modality the care manager is using, and what, if any, medications the PCP has already prescribed you. And that helps structure their week, their day, to really look across that panel, not just at who do I have a visit with in the next hour, but who aren't we helping yet? Who aren't we getting to? Who's disengaging or who's engaging but not getting better? And that structures an hour-long consultation that the care manager has with a psychiatrist. Not there for the psychiatrist to take over care, but they, in that hour a week, problem solve around those patients with the worst symptoms and those that aren't getting better. Part of what they're doing is directly documenting recommendations to the PCP to change a dose or diagnosis or things like that, to help individual patients, and then really help that primary care team level up and have a lot more confidence in managing a broader spectrum of conditions and a broader range of severity. Okay. So that model started getting researched in the late 90s. First massive randomized controlled study, 1,800 beneficiaries randomized, and all screened positive on the same depression score. 900 go get regular primary care, 900 go get this. And a year later, only 19%, so 1 in 5 of those patients with regular primary care had a massive reduction, had a big reduction of depression. It was either worse, about the same, or a little bit better. And in collaborative care, it's 50%. Had a large reduction, as measured as like a 50% drop in their depression symptoms. So it's like, if this had been a drug, 20 years ago, it would have already been a blockbuster. Sort of, it was amazing results, better than 2x uplift. And that got replicated over and over and over again in studies for depression, for anxiety, showing endpoints not only for your depression symptoms, but also your diabetes or your weight, and also on what's called total cost of care. Right. So it turns out when you control people's depression, they get cheaper because they don't go to the emergency department as much. Their hospitalizations are less frequent and shorter periods of time, things like this. And so I had the good fortune of being at the tail end of that, a huge amount of evidence that had come. And really there had been 2 barriers of why it hadn't scaled. One was like the money never really worked. And second is it's kind of complicated to put this team together. Right. And so a few months after I started learning about it, Medicare fixed the money side. So they actually announced that they were going to pay for this model nationwide. And that was when the light went off and said, man, someone needs to fix the complexity side. And yes, there's a lot of software that needs to get built, but our belief was it's not like every primary care medical group in the country saying, man, I desperately want to hire a bunch of psychologists, social workers, and psychiatrists. I just need a better app to help manage their workflow. It was like, no. I know I see that problem. I see a lot of uncontrolled depression. I love help with it, but this isn't my expertise. And that's really why we decided that there's always going to be a technology angle, but actually we needed to build a delivery organization itself and employ phenomenal clinicians that could kind of be an easy button for those teams.
Okay. So it sounds like there was a gap between coming back and convincing your wife that you shouldn't get a job and Medicare saying, hey, the money thing is solved. And that sounds like it was a few months. What was going on within those first few months? And would you have done the business if Medicare didn't solve the money problem?
there's a classic way, like once you find something you think is going to work in healthcare, like if the revenue model doesn't work, there's like a few places you go. Wealthy people, right, to cover it with cash, or self-insured employers, right? So you go to big companies that and that's like industry jargon we use. Like folks don't know. I mean, when you're a big company, you actually directly pay all the health claims. It's not United and doing it. They're just organizing the claims processing, but you own the risk on your own balance sheet. Once you're big enough, it's just cheaper to do that. And those places sometimes can be a hotbed for innovation because they can make their own decision if you convince people high enough in the HR and finance departments. And so, yeah, I was curious about that, and looking at it and looking at those two paths and seeing if we had something. And it's probably right at the end of the program. In the next couple of weeks, we had gotten word for some folks that like there was exciting stuff coming from Medicare. It just hadn't come out yet. So that was when, we were kind of waiting. I had never like refreshed the federal registrars much often to see whether or not there was kind of guidance coming out than I had that time. Because I mean, when Medicare, it's like this very opaque thing if you don't come from the industry, but whether it's CMS or FDA or FCC, right, whenever they're making new rules, they create this preliminary rule and then they ask for feedback and then they wait a couple months. And so, it's something you can sort of obsessively look for if you know where to look. And then they kind of, it's a basic process which they tell you what they're going to do, ask you for comments and questions and stuff like that, and then they finalize it a few months later. So that kicked off sometime that fall. Yeah.
Okay. And this was 2016?
That's right. Yeah. So the program was the summer of 2016, and I was still thinking about that palliative thing, kind of helping a few friends, and increasingly having friends ask me whether or not I was deciding to just be a stay-at-home dad or not, or like what was this next thing? Because it seemed like I was busy, even though I didn't work for anybody.
Really, really quickly, I want to jump in on this point, which is, as you were obsessively refreshing the registrar, were you kind of contingency planning on like what would this need to look like if we were to sell into self-insured employers?
Yeah, I was trying to have a lot of conversations, with folks to say like, yeah, who would the first customer be, kind of thing, right? Like, so beginning to say what's happening right now. This is probably about the same time some companies that are now big, able to existed already. I think Ginger existed, but was something different. This company Lyra that may have existed at that point, although I didn't know about yet, was sort of going to build a Goliath in that, targeting mental health tech-enabled services to employers. Yeah, it was also, frankly, probably my like founder market fit was not nearly as strong there. Like that is a sales cycle and industry in and of itself, right? There's a set of 2,000 or so employers that matter in that space in the United States. They like decide every fall, what their benefits will be and like how to get budget for it, and then roll them out at the beginning of the plan year that normally starts at the beginning of the year. And yeah, I've never operated. I like know of it, but I'm not in it in a way that I probably was less useful for on the commercial side than the provider market, where I knew more people and have spent more time.
What's your take? You bring up a point here that I think I'd love to dig in on. It's like, what's your take on founder market fit within healthcare, within health tech, however you want to describe it? Because like to me, it seems like you could go down a rabbit hole as far as you want to go, right? It's like, I only know how to work on selling to self-insured employers with XYZ qualities, or I only know how to work with unions on Taft-Hartley health plans, or I only know how to work with Medicare Advantage and risk-based scenarios. It's like, how deep do you need to be in order to be successful in healthcare, or can you be an outsider?
Yeah, I think you can be both, but I think you need to have a lot of humility to understand what you don't know, right? And I'd say teams in which the first 5 people are all know nothing about healthcare. They all came from some consumer app company, and they had like one personal experience and then are like, this system's broken, I'm going to fix it. I think they're a lot less, some can succeed, but they're less likely. I think also if your first 10 are all grizzled industry veterans and you don't get someone that brings an outside perspective, you may be successful, but you're probably under optimizing for the potential change that you can make, and it's sort of really integrating that, I think, from, competence around kind of commercial clinical technology, as well as sort of that insider outsider dynamic. And you probably need to understand what space am I driving at, and what combination on that 2x2, where do I need, where do I have personally and who do the next couple of people need to be to complement that for where I'm going. I do think that a problem you've got from outsiders is sometimes they get really excited around like, hey, we do a really bad job coordinating care between different providers. Like, I'm going to fix that. And it's like, that is true, but like, it's not like it's not like you're the first person to realize that. Like, the insiders have known we're crap at that for 50 years also. Like, that's not a business, that's like a whole sphere of the industry, right? And, so you need to have a thesis about how you're going to fix it, and I think in an industry like healthcare, it depends a little bit. Are you talking about that kind of 3 trillion-ish that flows through the money pipes of Medicare, Medicaid, and commercial insurance? There's a lot of businesses that are health related that can flow outside of those pipes. You could build a consumer business, Weight Watchers, and there's lots of massive companies that have been done outside and that are health focused but consumer dollars. But once you touch that $3 trillion of money, which is a lot of cash and a lot of stuff, you've really got to, I think, take the next step to understand, okay, which is the first bite of the elephant and where the dollar is going to be. And certainly you need to have a real product service innovation, how am I going to create value? But if you don't understand who's capturing that value now, who becomes my enemy, who becomes my ally, how do I make somebody money or save somebody money in a really concrete way, you end up spinning your wheels a lot.
So going back to where you're at now in 2016 and Medicare is changing its way, you also have this other side of the equation, which is you're like, well, in order to do this, I got to get PCPs on board. Like, that sounds like that was more in your wheelhouse, but how the heck do you go about doing that? And what does that process look like?
Yeah. So, I mean, the first thing before that even was finding a partner, right? Because it was like, the more I got conviction that the answer was a kind of tech-enabled service or full stack or medical group, whatever jargon you want to use, I knew how to talk about that, but I didn't really know how to operate one. So first I started asking everybody I met who was the best in the country at that, and met a woman, Verna Little, who is a psychologist and social worker, was one of the pioneers of this clinical model, and had made a great career and was a senior vice president of behavioral health at one of the largest community clinics in New York State, and had been kind of a national speaker advisor. And so I got her contact information and convinced her to spend a little time with me on the phone. And we got excited enough that convinced her if I flew out to New York later that week, if she spent an afternoon with me. And really that was when I knew, oh, Verna and I could do this together, right? Like, she really knows how to do this. She knows how to hire people, run this. We're going to do great care. And really it was a passion and expertise of hers that she'd spent 15 years building. And in many ways, Concert Health could become a manifestation of bringing her insight to a different order of magnitude level of scale that had ever been done in the before. And then taking that and extending on the insight, right? Because we're going to have so much more patient care than anyone's done. We can sort of not only work to the model, but eventually build on top of the model. So that's when I really got fully excited. It was like, man, I bet we could do this. We had to wait for a while because we had to wait for the Medicare guidance to come out. We had to understand how the pricing would work. If it was too low, and we didn't think we could build it, to create margin for anybody, it wouldn't have worked, all those sorts of things. That was probably like mid 2017 before, in which I was working on it close to full time. She still had a busy job, so it was just like an advisor. And that was when I was like, hey, we could do this. And then it was putting that pitch together, the value prop and how the economics would work. And then targeted, I learned something big, which was I knew a lot of people in big health systems, but this was not a place to start in big health systems, because none of them wanted to work with people that had no track record, an organization that hadn't done this before. So we realized pretty quickly that we were going to get more traction in very small groups that were less risk averse and were more willing to try something. And so decided to focus on suburban Phoenix because there's a lot of small primary care groups, and because it started with just Medicare. Fortunately, it's now reimbursed by every commercial insurance and Medicaid and soon to be 20 states. But at the time it was Medicare specific. And in Phoenix, you can kind of target geographies based on where there's largely retirement centers. And so physicians mostly just care for, Surprise and Sun City, where they just care for Medicare beneficiaries. And we knew to make this valuable to primary care, you had to help them across everyone they treated, right? And so that was easy. If you're in Sun City, all you treat is people with Medicare, so it's fine.
Yep.
And then it was, cold calling. I just did a ton of cold calling into those groups to try to get meetings. I
Okay.
used to kind of fib and say I sort of lived in Phoenix. My most dejected moment, I think this was maybe before we signed our first customer. I had fibbed and said I would I'd be like in the area and could I come by to see the doc? And the practice manager said, sure. She's really passionate about behavioral health and, doesn't have good insight. So then I woke up at like 3 a.m, started driving from San Diego, and she called me at like 7 a.m. to say that the doctor was going to be in the hospital and couldn't do it today. And I wanted to be mad at her, but I'm like, I lied, right? I pretended I was in the neighborhood, and that was why she was willing to give me 15 minutes. So, but she called me. I was in the middle of the desert, just past Imperial, California, and I had to like wait 10 more miles. I was past Yuma, so I had to wait like 10 more miles just for the next exit so I could turn around and drive back. Like I came home and it was like 11 a.m. I was exhausted. I got nothing done. And, I was questioning whether or not this market approach was good, the right one. So.
And I love that story.
Yeah.
You were cold calling, you're going out, you're trying to meet these docs. Like, what was the success rate? How many no's did it take to get to your first yes?
More likely than no was sort of the dying a slow death, right? Like the never got to no, but never got to yes and stopped answering emails or phone calls repeatedly. At least 50 probably. 50, 70 we had reached out to before we got our first couple. And then we wrote a piece in a trade magazine, MGMA, and we had a couple of physicians that reached out to that, medical groups that reached out from that. And unfortunately, we had just signed I think our first 2 Arizona partners. So then when there's like an 80 physician group that called, and we could say, oh yes, we do exist. We're not an idea. We have 2 partners, Yep. Like at the time we were probably caring for like 7 patients, but.
Yep.
That was going to be my question, is as you were cold calling and hitting the phones, what did like the products, like if you look at the whole service offering, what did you already have built?
Yeah, so Verna was getting her license in Arizona because we knew it was doing there. We had found a site consultant, meaning a psychiatric nurse practitioner who was based in Arizona that knew a little bit about the model, and she was happy to play the role of that weekly consultation. And then we had found a nurse and a social worker that were willing to work for us part-time, sort of thing, that we had a little bit of help to use them as subject matter experts. And that we're mostly waiting for patient care. Like one was going to go on maternity leave because she had a young child, and was sort of like, sure, I'll do this for like a couple hours a week. And then if this works, I'm happy to do 10 or 20 hours a week of care, sort of thing.
So,
and at that point, I'd started a sort of prototype. It's interesting. We could have saved a little cash. I mean, we could have like just managed those patients on a whiteboard. We had probably put in, $20,000 or $30,000, and some friends of mine helping to build out our early technology platform that would be kind of the population health, the care management platform to manage those patients.
God, that was going to be my question. Did you kind of like string together 1099s and then spreadsheet it for a while? But it sounds like you actually did get a jump start on the actual software.
Yeah, we had started to. The early work was modeled on top of Salesforce. And so essentially we had started that, used a small dev shop to do a little bit of customization, and then had found an early career technology professional that's still on our team, Sadie, that helped me kind of build out a lot of the early work. She was an A+ Salesforce admin, and I was like a C- product manager / business developer, and we did it. I remember that was another funny moment where she was sure the dashboard was wrong because I think it showed like 4 patients, and I was like, nope, that's right. That's right. But trust me, Sadie, we're going to be huge. Like, it's going to work. Like at the time she was doing it nights and weekends around another job. And I'm like, this is totally going to be a real thing that, will employ you one day. So it was right, but she was maybe right to be skeptical in that moment.
Okay. And what was the pitch to these providers at that point? Like, presumably you're saying, hey, you're going to get better behavioral health care for your patients, but also presumably they're going to have to spend more time to do this coordinated care. Is that true?
Yeah. So it was kind of, at first start with, hey, do you have problems accessing enough high quality behavioral health services? Everybody says yes to that, right? Like I have a ton of patients that have depression, anxiety. I am comfortable managing the spectrum of it, but many of them want and need therapy. I can't get them to it. I would love help on knowing prescribing which meds to use, what dose, and I'm on an island with maybe I was lucky enough to have a friend that from residency that went into psychiatry. Otherwise I'm relying on pharma reps or, one rotation back in med school sort of thing. So the clinical need was there almost universally. It's pretty rare you find a primary care physician that says, I don't have a problem. But then it was, do you know that Medicare now actually has a covered benefit, right? That will pay you to assemble a 3-person team, you, a behavioral care manager, and a psych consultant, as long as you build this thing called the registry that tracks symptom severity. You do these brief interventions. You have the psych consultant that is documented in your record, and you're tracking how much time you're spending per patient per month, and you're able to bill based on how much time you spend. And 99.9% that I did not know that existed, right? And so saying, okay, so you could either, like, here it is, it's in the public domain, you could go build this tomorrow, and then the question is, do you want to go figure this out yourself, right? Or do you want to work with us, and we'll kind of be the easy button. We'll employ the care manager, the psych consultant. We've built this registry. At that point, we were really selling Verna's expertise in much ways. Like she has done this at scale. She's a leader, and we're going to do it with you in a pilot basis. You're going to get kind of an A+ team to deliver this with you. And so the basic value proposition was patients will get better care. You'll save a little bit of time and stress in your day, and you'll make a little bit of money from these reimbursement codes, right? And those all come together in a way that'll help you be a better doctor.
Okay. And so then the payment flow is primary care physicians. They are the ones who actually do the billing via Medicare, and then they pay you guys some.
Yeah, we're sort of a subcon. Well, at this point now, soon to treat our 20,000th patient, working with 56 medical groups and health systems. The revenue side's gotten more complicated, and there's multiple ways we do it. But yeah, at the beginning, it's a primary care centric model, and we're essentially the subcontractor that's bringing the other 2 clinicians to bear.
How clear was the revenue model at the outset? Like, was it like, yep, we're definitely just going to subcontract out our clinicians and that's how it's going to go? Or did you try to go like something more akin to like a value-based model, like a PMPM type thing?
Yep. Yeah, we looked, once Medicare announced they would pay for it, that was really critical to allow, a more traditional low friction model. But we looked at a bunch in both directions. The problem with normally those folks that are taking, one is the word value-based care is used a lot. Almost always underneath that, it's really like a fee-for-service chassis with some cherries on top, right? Some shared savings or some quality measures. But underneath it, it still assumes a billing apparatus in which I send you this thing called the code and you send me money back, on a monthly basis. And that's how I keep the doors open. The other thing is that folks that have more and more risk models, true value-based care to population, are normally very big. And so they're sort of like, it's like, oh, so there's this model you've never done before and a new code that just started to exist, and you want me, giant health system, to be your first customer, even though I could probably do this myself. So, like that wasn't going to work. But the small groups, there's no way they're going to do this themselves. So why not take a flyer and try it is where we moved for sure. And a thing that we learned really quickly was it's really important. I think this came from almost certainly Verna's insight, being in the trenches before, is like, it's really hard to take a sliver of someone's panel, right? If there's a primary care physician, she sees 25 people a day, and you can help her with the one every other Thursday that both has depression and is in the right health plan. She'll say maybe, but go have at it. But I'm not going to change how I spend my day, But if you say, listen, you see 25 people today, 1 to 5 of them are going to have a behavioral health condition. I can help you with all of them. Then it's like, oh man, that's great. That's how I want to practice. That changes my life. And so that's why we really that's why we targeted, Northwest Valley early of Phoenix, and where we've really tried to stay true to is work and geographies where we can bring a, full panel solution to the primary care physician.
Yeah. I mean, it kind of harkens back, at least on the software side. It's just like, you want frequency of usage. Because if you don't have that, then providers will just kind of forget, or it's just not acute.
Yeah, and even if they allow it to happen, they don't pay attention to it, right? And the research showed over and over again what works is that the care manager, the psychiatrist, the PCP are actually collaborating, right? You're actually changing the frequency with which they diagnose, the accuracy of that diagnosis, and you are titrating the intervention more quickly based on whether or not it's working, right? And so that doesn't happen if the PCP forgets you exist. Even if you find a way to get the volume, you don't actually change the point of care decisions that make people's outcomes better.
Yeah. And kind of going back to your earlier days, I think this was probably while you guys were waiting for CMS to release something. What did your fundraising look like through this? So coming out of the 10 days, you found Verna, you're like, hell yeah, I have my world-class team. Did you have financing then? Was it off a pitch deck before you had to go higher? Like, what did it look like?
Yeah, I'd raised a lot of money in my first business early, and from the beginning had an investor-controlled organization because of that, and I didn't want to replicate that. So I was pretty dogmatic about bootstrapping. The biggest investor in the business was my wife. We'd had a lot of success at my last business, and just professionally, we were great. She's an attorney and was making a great salary, and so we had a bit of a nest egg, already owned a house, and really it said we made two bets. One was I'm not going to take a paycheck for a while as I learned this, and the second was we're going to put money in the business. The original plan was up to 50,000, although I remember in the first meeting I said 6 months 50,000, like kind of like that's my first pitch deck for my wife, and she was like at least a year and 100,000, but I'm in. And she was like right on the 100 grand, and it was 18 months I think, or something like that. So she was a better judge of my prospects, or at least my speed, than I was. And so we're really focused on we're going to prove the clinical and economic value proposition on our own dime. And that was why Verna was doing nights and weekends. She started then working more, but it was all self-funded for that first year plus. And then when we really had conviction, we had a few partners. They had gotten paid and they were happy and they wanted to expand. Then we raised about half a million more in what we call the pre-seed. And that lasted us about a year. And then we raised a $2 million seed round, which is the first time we had kind of institutional venture capital. It was that was in 2019 when Anya Sheese took a bet on us at Healthy Ventures, and she anchored a $2 million seed round.
Can you talk about what it was like? Because I think that's amazing to have. I mean, the privilege, but also the risk appetite to say we're going to actually bankroll this for as long as we can, such that we can actually prove out track record and that this thing works. What was it like walking into that then $500,000 fundraise, knowing that you had a bag of data saying this thing really works, we have real customers? How did that feel?
Yeah.
It probably felt amazing.
It was, yeah. I mean, it certainly was not. I mean, it felt a little bit nerve-wracking. I remember like you planned to have, but with traction came a real payroll. We started to bring some of those people more and more on, and it was like, $5 or $7 grand a month turned into 10 or 15 or 20. And that was like the time that I needed to like write checks. At that point, we were financing this on the HELOC of our house, right? So it was like sort of writing money we didn't really have. And it was like, oh man, this is getting to be a bigger ask, on the part of my wife. So it was nerve-wracking from that perspective. I think we had a real thesis too, that technology is a big part of this, but we were going to build a medical group that still turned off a lot of institutional investors, which is why that became the biggest investor was a former boss of mine that runs a consulting firm. It was actually the meeting space that Verna and I met in that first one. And so I came back around and sort of said, hey, I'm ready, like this is real, but we did it. And so that firm put some in, and then it was other entrepreneurs that I knew, some folks I went to grad school with, those sorts of things. It was really like, and then what we did was took our investment and kind of rolled it in on the same terms as everybody else. So it was like, hey, Lori and I were the second biggest check into that round, and it was like, hey, let's really focus on a deal that's a win-win for everybody, because we were certainly most over-indexed to it financially of any of those people that put the early cash in.
So kind of read between the lines on the corporate structure. It sounds like you have the professional practicing group that Verna sits over, and then you have the corporate entity that you guys kind of, you really chair over.
Yeah, there's both because there's a whole bunch of work. And it depends on the market of whether or not, some states it can be a single entity. Some states you need to have a separate professional corporation. Yeah, where that employs the clinicians, and then they work with or contracted with the Concert Health Inc., which is a MSO, is the Language or Management Services Organization.
Awesome. Yeah, that's a we are. You're the second company we've ever interviewed that has that structure, so we're always trying to get a little bit smarter on that
Yeah,
front.
I mean, it's that's one of those classic, like it's a known problem. It's not innovative. A lot of people have done it. It certainly is a whole new world if you're not from it, and drives the legal bill up quite a bit at the beginning because it's not as simple as a Delaware C corp that you put together, and you have to think about it. And then create real divisions of that, of clinical responsibility versus administrative oversight, and set those up, in a way that's consistent with both the letter and spirit of the law. And it's very market dependent, right? So, it's why when you move in that direction, a lot of times you talk about um, it's a difference between the self-insured or the employer market, in which a lot of times you try to stay on the other side of kind of quote unquote practice in medicine, because the employer wants you to work across state lines in a way that's hard to do early on when you're building, you're actually delivering clinical healthcare services.
Yeah. So as you started, you cut your teeth on smaller provider groups. Can you talk through that evolution of working to maybe multi-site groups to then larger systems, and also you touched on sales cycle of like it was almost like this appetite of longer sales cycles, more complex sales cycles. Health system sales cycles, from what we've learned, are some of the
Yeah,
worst or most complex. Like, how did
yeah.
that grow that in that direction?
Yeah, when we started, we really didn't think that big health systems would be a partner for a long time. Is that if they believed in this model, they'd think they could hire and do it themselves. Maybe they'd want to buy an app or piece of technology, but they wouldn't want to buy the clinical services. I knew those big health systems; those were our partners at my last company that I interacted more at the FCC and my role as a consultant. So a few of them, I kind of keep them in the loop on what I was building here. This is what we're doing at Concert. This is what we're trying to solve for. We're not ready for you, but what else are you seeing out there? Those sorts of things. And then, probably within a couple of years, a few things happened. Was this really went to the top of their agenda? That said, even before COVID, like the institutions of healthcare have underinvested in behavioral health, and specifically to solve the problem, more and more people are getting to this. It needs to be integrated with primary care. That's the only place we'll have access, and the only place where we can drive the outcomes that'll allow it, right? This intersection, we have to stop thinking about mental health care somehow totally different, and about that point, we said, well, we've taken care of 1,000 patients, a couple thousand patients with some small groups. You know, we could do it with you too. We couldn't do it everywhere, right? But we could do it in some pockets. And so, we gotten more and more, based on Verna's reputation. We were working with some great mid-sized groups in New York. Sun River Health, it's now called Sun River Health. It's a 20-site federally qualified health clinic. We began to work with Saratoga Hospital, sort of a big acute care hospital in Saratoga, and so some nice regional systems. And that was about when groups like Common Spirit, really got engaged. And the approach we took was like, listen, and it's still the approach we take now. Like, we're not sitting around with like an extra 175 clinical social workers just waiting for the sales call to go well, and we can like turn on our capacity. But this is all we do. We wake up every night figuring out how to scale and build collaborative care, and all our recruiting infrastructure is focused on hiring great and training great clinicians. We're always thinking about supply and demand management. That is all of our technology focus is there. And so, if you want to build with us, it's going to be one of one priority, not one of 100. And I think that having that transparency to sort of say, this is where I am, these are things that we're proud of and we really can prove. We really have taken care of hundreds or a couple thousand people. Here's how much their depression symptoms got better. Here's demonstration that they're getting paid, and that it's a sustainable model for them. And then also, here's where we're not, we're being transparent, where we haven't scaled to the scale that you need, but our bet is we'll do it better together than you would by yourself. And at least a couple of folks said yes to that. And that really helped us. And like almost any kind of highly regulated industry, or I don't know, I mean, healthcare is an interesting dynamic in which a bunch of big health systems, they really only compete with people very locally, and so there's a lot of cross-talking across, and constantly talking about who's complete baloney and who's actually delivering value, and they're happy to sort of be reference accounts in a way that can be really dramatic once you really do nail it with one of them.
Yeah, so definitely having that track record leading up to it, but then also the connections through Verna's network
Yeah.
was key in getting at least the early larger systems.
Yeah, that was a piece. Although, one of our first groups in California, or our first group in California, is the 40 physicians in El Centro, called Imperial Valley Family Care Medical Group. That was a cold call right off their website to their practice manager, and um, he said, "Listen, we've been looking for something like this. It's a huge need out here. Like, if you guys are legit, come out." I think a lot of it is, I mean, this is one of those things about if you're not an insider, right? Like having respect for the insiders to a certain extent. Like, it's normally not like people aren't just all incompetent and evil, right? Like, I mean, there's some of that, both of them in the US. There's not none of that. But like normally the reason I haven't fixed some of this stuff is like it's actually hard, right? And so sometimes people say like, I have this amazing user experience. And it's like, I love that user experience, but like you have to live with me in the mess of the weird regulatory dynamic, HIPAA, how do I make money on this? Like if and so I think sometimes people, they try to hoist the hardest problems on their customer to say like, listen, I'm going to help you do this great job engaging patients. You figure out how to make money with it, right? Or you figure out how to brand it to your customers, and it's like, listen, that other part is oftentimes just as hard, sometimes harder than just the user experience or the intervention flow. And if you live with that of, in our case, it was, here is the code, here's the rules for the code, here's how our team is going to help you fill out the claim form, right? Here's how we're going to work to make sure that it really does. And then also here's how we're going to train your providers so they're your PCP, so they're excited about this and don't hate it, right? And aren't pushing it off. And it's, it's those pieces that end up going, oh wait, this really, this rises above the BS that everyone calls me about.
Can you spend a little bit talking about that one? Because that's super interesting to me, of getting providers excited. Like, it's one thing if you sell into a practice and maybe early days, you the person you were selling to, the buyer, the decision maker, and then the end user was the provider, was the PCP. But can you talk about the onboarding process in the early days? Like, what did that look like of getting them excited?
Yeah, you're right. That's another nice thing about the smaller groups is that normally it's owner, CEO, CMO, CFO is the same person. It's or a small group of individuals. It's a five provider practice, two of them own it or something like that. And you're talking with them, but they're going to be the first users. So I'd say, for our case, it was, we know what we're talking about. It was, Verna is an expert clinician, right? And that our first couple care manager and site consultant knew what they were doing, and could really help them. So they'd say, we didn't really need to convince them, oh, there's a lot of untreated depression in the world, and that's the, skip over that stuff. You don't need that slide deck, but like, you could really help me. That's it clinically, right? And then the second is, you can help me figure out how to build this model together, that it's not this crazy profit center for me, but that we have a way that I can kind of get properly compensated for the time I'm invested in this, and I can build something, and that was harder than we thought. I mean, it was like, partially this was because we were bootstrapping. Verna was doing this nights and weekends or part-time originally. And, if we could rewind, it would have been really investing in real billing nuts and bolts expertise early. Because I think we whenever you can say there's a CPT code, but like, what goes on the claim form? What diagnosis does it need to be? What day does it need to be dropped? What date of service? And really figuring that out for each Medicare Advantage plan, and Medicare itself geographically split up into these things called MAC, so it's a little bit different. And I think Verna probably had some of that expertise. I was just learning about it. I could talk at 100,000 feet. She could probably operate down pretty close to ground zero, but because she was nights and weekends at the beginning, was operating at 10,000. And when it really started to work is when we got a team that was going to operate ground zero on those logistics. That's the hard part here is like, okay, and is it going to work for every health plan, right? Because that vision of all panel resonates really clearly with primary care physicians. It makes it very easy to sell, or easier to sell to them. But delivering that on that is a heck of a lot more complicated.
Yeah, I totally buy the billing complexity. and nuances with specific payers or CMS
Yeah.
itself. How far into your journey did you have to wait until you brought in that medical billing expert to help kind of streamline things?
Probably 2 years, and it should have been 6 months.
Hmm.
Right? That was like,
Wow.
we would have avoided a lot of pain. We were relying on me and Verna or favors or asking, kind of working with their billing team. But in reality, what we were doing was we hoisted too much of the problem on the billing teams of our early partners for sure. And some of them um, made a bunch of like, mistakes that originally we thought were like, oh my God, they're incompetent. But then when you look back, there's some of that, like they didn't do it or they weren't good communicators. But a lot of it was like we didn't engage them as peers. We didn't realize how much we didn't know, and we didn't have a team that was like, no, I'm going to like make sure this happens. Because in many ways, they were doing us a favor. We were dropping the first few dozen claims. They were figuring out who was paying, who wasn't, why weren't they, why were they denying? And like that was something that eventually we had to own and say, hey, this is really going to be one of the major friction points of the business. We need to invest in it ourselves, and we need to be adding value here, not asking you for things.
Yeah. Um, I want to spend a little bit of time because it sounds like you guys are remote as a company. Is that correct?
Yep.
How, like, was that intentional from day one? Was that because, oh, Verna's in New York, I'm in San Diego, like that's just how it's going to
Yep.
be? Or
That's how it started for sure. I was having enough trouble convincing her to do this nights and weekends, much less like, hey, can you move to San Diego? And I can't pay you, and you've got a kid in college. It was like, no way, right? So it started as a necessity, right? She was the right partner, and we didn't live in the same city. At some point, well before COVID, we decided though that it was the right way to go. And mostly it came from, I think a lesson that we were observing was that too many people that were building these tech-enabled services businesses, it was too easy to think about the software team and the headquarters as the company and the clinicians as part of the product. And oh yeah, we 1099 them, they work somewhere, and we didn't want that to be how we built it. We didn't think that was the way to build an organization aligned with our values or that would be most successful. And so it said, listen, we think that the remote model is core to our talent strategy clinically, right? It's how we're going to attract great people that don't want or need these other jobs. And it's going to be an effective way to deliver the service. And then it was saying, if that's going to be true, why don't we eat our own dog food, in order to do this? And we started to just find really talented people. Verna moved to South Carolina at some point. We found that revenue cycle leader. It lives on Long Island. We found our product and platform leader lived in Seattle. And at first it was like, well, you don't have to move now. Maybe one day we'll centralize in San Diego, and San Diego is a good place. And pretty quickly it said, listen, like we're just committed to this. Let's just figure out, if 90% of our employees and our most important employees, the clinicians, are going to be working from home, the rest of us can figure that out too.
yeah, highly aligned in that regard.
Yeah.
All right. Well, this is we're getting close to the end here. Let me close with one question, which is, if you weren't doing Concert Health today, what would you be doing?
I don't know. There's so much opportunity. I would say that, what I am inspired by for someone in my background, right, that knows how to start things, that knows how to sell things, that knows how to build teams, but fundamentally can't do stuff, right? Can't heal. It's, find, I loved the model of Concert, and I think there's just a lot out there, which is find a clinical model that really works, right? Find in the future that doesn't just make sense. It should make sense, but it also has built evidence right around it, right? And it's being operated in a medical center somewhere or in some pilots or some research somewhere. And then figure out like why the F hasn't it scaled? Why aren't we living in that future yet? And normally at the nexus, some combination of like, we haven't figured out the money and we haven't figured out how to operationalize it, and I think there's a lot of businesses to be built there. There's another team in San Diego that I have a lot of respect for, Equip Health, Christina and Aaron, building also the behavioral health space, but building best in class eating disorder treatment in a virtual model, and just amazing work that they're doing and getting out the ground. I think there's just so many of those for segments, kind of any medical specialty, any major diagnosis, like, some of those things, there's almost always pockets of when we figure out how to do this better than the rest of us are getting. And how can you use both business operating culture model innovations as well as technology innovations in order to solve that problem. So I'd probably go find another Verna and figure out if I could, build something like that.
Very cool. Well, thank you so much for joining us, Spencer. This has been really, really wonderful.
Yeah, it was a blast. Thanks, both of you.
So what'd you think?
I loved the conversation.
Same.
I thought it was actually extremely helpful to aspiring founders, because I think he gave one good, often founders like, where am I going to get my idea? What's my idea? And he gave a really great framework, I believe, for a certain type of healthcare idea.
Yeah. And then he gave another kernel of an insight on how to find even more, which was just go watch CMS for guidance and pounce on that shit.
Right. Yeah, you could do that. And then the other one is more or less watching something, which is not fun to watch, but crawl through clinical studies and trials, find an innovative something or other, model of care, program, whatever it is, that was effective. Then you ask yourself, well, if it's effective, why hasn't it scaled or been more widely distributed? And then he said, more or less, you're going to look at, well, what's wrong with the money side?
Yep.
And has that changed? Or what's wrong with the operational side? And has that changed? And if you can solve those two things, you might have a great opportunity.
Yep.
And I loved that, because the whole time I was thinking through, oh, well, we're kind of doing the same exercise on cognitive decline.
Yeah.
So
completely.
For anyone who's listening, be our guest, go steal it, but we're going to probably work on it.
Come work with us on it.
Yeah, come work with us on it.
Yeah.
Don't steal it.
Yeah. Yeah, totally. And the other thing that I found really great at a super high level of this conversation was, we've talked to some people and they're like, never sell to providers, and other people, oh my God, I only want to see companies that are selling to providers. But I've never actually seen or heard about a business firsthand that is selling to providers and doing it really successfully, and what it actually took to go do it. And now I'm like, oh, got it. Now I understand how you actually sell to providers. It makes so much more sense to me now.
Well, but the funny thing is, yes, unique incentives and value props aside, motion's the same as every other single startup. Yep. Same as Ryan Grant, who I guess was selling to providers. But everyone, Cena comes to mind. At Naya, it was cold call.
Yeah.
And it's going to be roughly about 50 to 70 before one hits.
Yeah.
So if you're a founder, you need to be selling. And if you're a selling founder, that don't expect anything positive to happen until 70, 75.
Yeah, right. You should probably always just mark yourself hey, I'm gonna cold call 250, and if I don't get a couple of bites in my first 250, I can kill this thing.
Something's wrong. Either you tweak your target or you tweak your pitch. But I loved that, because it was just another hit in the face of, it's hard.
Really hard.
So just go do it.
Yep.
I at the very beginning of his story, I loved the 10-10-10.
Yep.
The 10 days. And I was thinking through, oh, well, that's a lot of what we think about, of how do you think through ideas fairly quickly. And he put it in a very fun way, which was, I had an egregious amount of access to people, to the right people, of getting 45 minutes with the right person overnight.
Yep.
That would have taken him 8 weeks. And more, it does feel like healthcare is not per se unique, but certainly more intensive in this regard, where access to the right people with the right knowledge, if you can speed that up, you can know something, you can have an idea way faster than usual.
Yep. And I think it's interesting to add into that, one of my key takeaways was the importance of the early team, even if it's just advisors, right?
Yeah.
Sounds like without his partner, deals wouldn't have wouldn't have happened. He wouldn't have understand the way to actually operationalize this thing. It just would never have taken flight. But it wasn't like she was a full time. She was an advisor.
Right. And that dovetails it. I have the same thing, which I had written down in caps or whatever it struck me in like a CAPS thought was find the expert and hire or partner with them.
Yep.
And I've also heard where, and I think this resonates and jives with Spencer's experience, which is you don't necessarily need, well, actually, I'm not sure that it does because she was so operationally involved, but you may not need a CMO at the very, very outset, full time.
Mm-hmm.
But get them involved as early as you can, as much as they're willing to contribute. And then probably over time, that's going to evolve into a full-time or co-founder relationship. And that's for the better of everyone involved.
Yep.
Another plus one, Nick Soman mentioned this, Molly Moore mentioned this. He's now mentioned this, humility and being an outsider.
Yeah.
Of realizing you don't know a lot. So just be cool with that and have the right mindset. That continues to be true.
Yep.
And even when you think you know something, you just don't.
Yeah.
So just move past it.
Yep. I really enjoyed his pragmatic approach. I'll call it pragmatic approach to fundraising. I mean, he with $100K of invested cash into the business and no salary for 18 months, even that isn't a lot of money for 2 years to get this business off the ground, followed by only a $500K pre-seed, a $2 million seed. Like, we're in 2021, that was 2018, 2019, something like that. But still, like, with his background, with his experience, I think with what he was proving, he could have raised significantly more, but he was just much more pragmatic about it. And I don't know, that speaks to me as a founder of like, why go raise as much money as you can humanly raise? I don't know, just like, I like hearing that. I like hearing that he was able to do it it doesn't require millions of dollars to get started in this world. Like, you can get started relatively cheaply.
Yeah. What was his, I don't know this. When was his Series A?
2021, I think.
Okay.
Yeah, it was a 12 million this year, I believe.
Yeah. I do like it as a proof point that you don't need a bucket of money to get going. Obviously it's a luxury to be able to do it the way he did. However, It was his luxury, his privilege. He did it and it worked.
Yep.
I do love I hate this, but like the more typical, like he's a businessman.
Yep.
That's the way you start a business. And we've heard other people say well, I don't know that this is a good idea yet, so I'm not going to take other people's money until I know it's a good idea.
Yep.
Plus, to his point, like I would like a little bit more say or control in this venture. So I'm all for that if you can make it work.
Yep.
All for it.
Yep.
The other thing I loved was his evolution towards building a remote company because of clinicians, because the nature of the business was such that, well, we're going to be servicing patients across the entire country. We're going to have clinicians that are going to be across the entire country, remotely distributed. Clinicians are the most important employee. Thus, why would we build a corporate headquarter that goes against that? Let's just be aligned with that, which I think is, are clinicians the new engineers?
The engineer in me says absolutely not. But maybe. Yep.
So,
especially, when you just start to think about the fact that clinicians are getting burned out like crazy because of the last year across the board, they're like, why the fuck am I doing this? And they're also getting hit up like crazy from recruiting firms saying like, hey, come work remotely now. Look at all this opportunity remotely.
Right.
Like, yeah. I mean, you can be a cardiologist remotely. You can be a nephrologist remotely. Right.
Right. And the pay as good, if not better.
Yeah. I mean, I guess I don't know, but you would think it's probably as good, comparable in some way.
Well, I have a sample size of one, knowing someone who was in a health system, did remote as a bridge, and now at a not health system job as still a practicing or licensed physician, and pay is good.
Yeah.
So maybe there's an argument to be said that, physicians are the next engineer.
Yeah. I mean, kind of scared for the future when no physicians work in hospitals anymore, but
well, maybe we'll just be going to a string of private companies instead.
Yeah, but they're all going to be like telehealth remotely.
Yeah, everyone's going to push it to
We'll
video
quickly
first.
we'll quickly get robotic surgery so that the surgeons can stay at home, I guess.
Yeah, exactly. But I like that. I assume we'll see more of that because of the push for virtual, and cross state lines, rigmarole. Yeah, I really enjoy. Like, I thought, pound for pound, Spencer had a lot of
meat.
a lot of meat in that conversation. And if anything, it's just like, starting these things are hard. You're going to get rejected. You're going to be 4 hours deep into a cross state drive because you lied on a cold call. Yeah. So just stomach it, turn around, go to bed, and wake up the next day.
Yeah, and I mean, like, the flip side is he got an email with Verna and was like, I'll get on a plane the end of this week, and that one worked.
And he did.
Right?
Yeah,
it worked.
Exactly.
So.
Like, you got to put yourself out there. That's an okay white lie. If you end up making it happen.
Yep. Cool.
So.
All right.
Yeah.